Thank you, everyone. This is Don Clayback with NCART. We appreciate everybody making the call today. We're going to be talking for the next hour or so about the COVID-19 situation that we're all dealing with. We wanted to have this really as the first in a series of calls on how we can manage through this as from the CRT industry's perspective. Today's call is being hosted by NCART, NARTS, U.S. Rehab, and the Clinician Task Force. So we thank them all for their support, and they've all been actively engaged in the work we've been doing. So first thing we want to do is, again, welcome everybody to the call. These, as we all know, are challenging times for our country, but also for our industry. There's a lot of issues that everyone is faced with right now that some of which I think we are identifying some solutions to. Others, we have still some work to be done, and we'll talk about that as we move through the call. But it's great to see what's been happening over the past couple of weeks, where we've seen, you know, the folks that supply CRT, whether it's providers, manufacturers, clinicians, the disability organizations, or others coming together. It's been a great sign of support, and I think sets the tone for us to work through this collectively. And on the screen, I've got a quote that Mark Cuban had put out a little bit earlier in the week, basically saying you don't have to be the leader to be a leader. We can all contribute. So I think that's something we can all kind of rally around. We all have our roles to play, and part of what we'll talk about in today's call is how we can effectively collaborate, which means, you know, our national associations, we want to be working on your behalf, but also we're interested in what you're doing on the ground level and what we can effectively do together by sharing information in a two-way manner. I should mention also that we'll have this PowerPoint will be available. We'll be sending it to everybody who's on the Access to CRT mailing list, and I'll talk about that in a minute. But then also NARTS and U.S. Rehab and NCART will be posting on their website and circulating that. So if you're not viewing this on your computer, you'll be able to get a hard copy, and there's links and other things that you'll be able to get once you have the document in front of you, and we'll get that out later today. So what we wanted to do on today's call is, first of all, bring us all together. As I mentioned, it's been a hectic couple of weeks, and we've got more challenges ahead of us, but by making sure we're communicating in addition to the email alerts that we've been putting out, we also want to have these webinars, and we're going to set one up, at least another one for next week, and we've talked about the possibility of having these at least on a weekly basis as we move forward to provide a gathering point in addition to the periodic emails that will be going out in the interim. We wanted to review what has been being done in terms of trying to identify the issues and answers and share what we know as we sit here today, but also what we're still working on guidance from, or guidance for. And then finally, as I mentioned, we wanted to create a forum that will allow for us to share information as we navigate through the weeks and potentially the months ahead around the COVID-19 crisis. So on the screen, you'll see we've got some initial contacts for you to follow. There's my email as Executive Director of NCART, Wheezy Walker, Executive Director of NARTS, Dan Fedor, Director of Reimbursement and Education for VGM and U.S. Rehab, and Kathy Carver, Executive Director of the Clinician Task Force. So there's a lot of others that have been working on our collective work, but these are the four contacts that you can use at least as initial point people as we move ahead. So what we've done up to this point, and for those of you that have been getting our email alerts, and hopefully that's mostly everybody, you should be aware of some of the activity that's been going on. But on today's call, we wanted to share what's been happening up to this point to get everybody on the same page, and then we can provide detailed updates as we move ahead. So the first thing we did is we did create an industry COVID-19 work group. So that consists of providers, manufacturers, clinicians, and others within the industry that are looking at how we can best continue to serve the folks that we provide CRT to. We then crafted a formal letter to CMS regarding initial changes that we needed from a policy perspective. Subsequent to that, we did get a response, and we've had in-person calls with the CMS teams, along with ongoing emails and continued discussions that I'll talk about in a minute. We've also sent out letters to the various state Medicaid programs, and we're in the process of following up on those. And then we've also collaborated with our other advocacy partners, so the American Association for Home Care, VGM, US Rehab, and also the state associations that have all been very active in our collective outreach to set the stage for us to continue to provide the products and services that are so important. And then finally, there's been a variety of other kind of one-on-one conversations. All of these efforts have really been designed to get the initial communication out to policymakers on what the challenges are relative to CRT and to DME, and then to identify what we need from a relief perspective, and then work with those policymakers on what they can do within the parameters of their own structure. So the next thing we want to talk about is the big picture trends, because thankfully there are some positive trends that I think are going to help us get through the challenges that we're facing. The overall, from the federal and state perspective, there's, I think, a definite commitment to minimize the barriers to care. So relative to whatever that might mean, certainly we know what that means from a CRT perspective, but it applies to a whole gamut of services. You know, hospitalization, surgery, prescription drugs, home health care, all those things that people are relying on from a healthcare perspective are examined, and there's been already a lot of relief issued, at least initially, to minimize the barriers to care and to reduce the burden on the healthcare system, so that if we're looking at hospitalization and inpatient care, acute care, that those systems are going to be able to manage what's been referred to as the surge that lies ahead. The common themes that we've been seeing in these discussions, and again, I think it's very encouraging, you know, is that the policymakers are really looking to how they can open up the pathways for care, how they can minimize or in some cases eliminate the need for physical contact, as we all know the reasons for that. And then, as I mentioned, reduce the burden on healthcare professionals and on the facilities so that they can focus on the priority in terms of medical care and patient care. And then finally, looking at the documentation that's required in these settings and what can be relaxed that, you know, is going to allow people to spend time on the important things and not get hung up on forms and other paperwork that really is a very low priority given what everybody needs to be focused on. So we also wanted to make the comment that over the past 2 weeks, you can imagine the amount of work that these policymakers have been able to manage, whether it's, you know, CMS on a federal level or the state Medicaid organizations or managed care organizations. You know, they've all been working and burning the midnight oil on this, along with our federal officials that I'm sure everybody has been watching on a daily basis via news briefs and other things. So the good news is they've been working hard, and I think it's pretty impressive, the initial guidance they have issued. The bad news is that guidance doesn't address all the issues, but the policymakers acknowledge that on some of the state calls and even on some of the federal calls we've had with CMS. There's a recognition that, you know we haven't solved everything yet. We're trying to address the immediacy and to give the relief that's needed. But as we issue waivers or issue policy changes, they do want to hear feedback on what still is missing and engage in that dialogue. So I think both those points are important, that there's been initial guidance issued, which is heading in the right direction, and there's a recognition that more needs to be done, and that's where our continued outreach comes into play. So the areas that impact CRT from both a evaluation, prescription, funding, and delivery perspective, we've got on the screen. So obviously wheelchair seating and evaluations that have a particular role for the PT and OT, along with the RTS employed ATP. We have the deliveries that need to continue, and as we all know, those deliveries involve fitting, adjustments, training, and other services. We have repairs that are needed, and certainly that's something we've stressed with policymakers, is that, you know, when we look at CRT, and I probably should have started with this comment, although I know I'm preaching to the choir here, when we talk to policymakers, we're introducing the priority for our services, highlighting, you know, the people that require CRT are unfortunately at high risk for both respiratory complications, but also other significant complications such as skin injuries, pressure sores, you know, wounds that could require their hospitalization if they don't have the right wheelchair, if they don't have the right cushion, if their wheelchair is not maintained in an operational manner, i.e. somebody may have a wheelchair, but if that breaks down and that person now is forced to remain in bed for several days because that wheelchair is not operational, that person is going to be at a high risk, and that's what we want to avoid. Some of the messaging has been around, you know, when they hear the term wheelchair, they may think, well, yeah, wheelchairs are important, but they're really, you know, not a priority right now. We need to draw that correlation that we're talking about complex wheelchairs and other complex equipment. And the fact is, if people with disabilities aren't continuing to have access to this equipment, they are at high risk for complications that could likely end up with them in the hospital and having to go through whatever medical intervention may be needed. So that's an important point that we need to make, because as the policymakers prioritize things, we need to focus on, again, the respiratory side and the potential for medical intervention that necessitates us being able to continue what we collectively do. So new items and repairs is another area. The documentation side, which we'll touch on, and then obviously prior authorizations, which, you know, focuses also or brings into play the documentation piece. And then finally, the customer and employee safeguard. So as we're looking at, you know, safeguarding both the customer and employee, whether that be the ATP or the repair technician or the OT or PT, all those things need to be kept in mind. From a Medicare perspective, the request that we've put out is, one, we're looking for a waiver of the face-to-face requirements. Two, we're looking for the allowance of remote technology for both the clinician and the ATP, and those activities that involve in-person contact. So that would be the specialty evaluation, the ATP participation, and the home evaluation. We're looking for for PTs and OTs to be able to bill under the telehealth benefit, and I'll come back to that in a minute. We're looking for relaxed provisions if there's situations where somebody has an urgent need for replacement or for a new piece of CRT. And then finally, we're looking to make sure that there's not a barrier for repairs. So we're looking for repairs to be able to be done without a confirmation of the medical or the continued need by the physician. So those are items focused on the Medicare front. On the Medicaid and commercial front, as we all know, these have different policies in place. So each one of these bullet points has a different different characteristics or different needs based on whatever that Medicaid policy is or whatever that commercial payer policy is. But we have similar requests. Again, waive the face-to-face requirements, again, to reduce the burden that's being placed on the healthcare professionals and also minimize the in-person encounters. Allow remote technology, as we mentioned. Waive prior authorizations for repairs. And for prior authorizations for other areas, we're recommending that at least there be some sort of dollar amount established so that basic replacements or new equipment can be provided with really minimal documentation and time delays before the person gets what they need. So we've set a dollar amount of allowing prior authorizations only for items that are over $1,000. And then finally looking again for relaxed provisions when there's urgent needs for new or replacement equipment. So these are all things that come into play when we're looking at things from a commercial or a Medicaid perspective. And again, these are individual conversations, but those are the themes, if you will, that we're using when we're talking to states or commercial payers. Now, there have been some good things that have been coming out again on both the legislative front and the regulatory front. On the CARES Act, which was signed by the President on March 27th, provides a broad menu of relief. There's, from our perspective, there's authority that CMS has to expand telehealth beyond what it's currently covering. There's a large number of business benefits. There's loans that are available for small businesses. There's also other relief that's available from a business perspective, and we'll talk about that a little later in the presentation. From the CRT and DME side, there's a suspension of the current 2% Medicare cuts that have been in place. That suspension goes from May 1st till the end of this year. There's also a continuation of the Medicare rates, the 50-50 blend for Medicare rates in the rural competitive bidding areas, and also it establishes the 75-25 blended rate for other non-competitive bid areas. Now, these extensions are available through the end of the COVID emergency, and certainly that's yet to be determined when that will be, but those do provide some significant relief. On the regulatory side, we have a interim rule for comment, which was put out by CMS and does contain some significant modifications or relaxation, if you will, of regulations that fall under CMS's jurisdiction. A few of those is we want to highlight that have an impact on CRT. Again, some of these are positive and tied to the requests we've made. Others are require a little more work on our part, but seem to be heading in the right direction. So we'll just review these. The expansion of the telehealth services. This is a particularly complex bullet point, if you will. The good news is CMS has expanded the services that are available under telehealth. So now most of the codes that a PT or OT uses when they're applying services to somebody who would require CRT equipment are included. The one significant one that has not been included in the list and that we're adding for is the wheelchair management code. So we're actually engaging CMS as we speak on our request to add that code to the services that are allowed under telehealth. But more importantly, once the codes are approved, we need to make sure that the OTs and PTs can bill those codes and provide those services on a remote basis. And unfortunately, right now, PTs and OTs are not considered from Medicare's perspective as clinicians that can use telehealth. So even though those OT and PT codes are listed, right now OTs and PTs are not eligible to use them, again, from a telehealth perspective. So we're hoping we can make progress on that, but right now that's one of the key issues we're focused on, as is the AOTA and APTA. Next item was on the relaxation from an NCD and LCD perspective on the requirement for in-person services. So when we talk about in-person specialty evaluations, in-person ATP engagement, in-person home assessments, reading through the regulation as it stands, it appears that those things are being relaxed during the period of COVID-19. So that's a big improvement. We are looking for some amplification from CMS on that in terms of what that means in terms of documentation and other things. And we hope to have that, in the next day or two so we can provide some additional guidance. They also lifted the face-to-face telehealth restrictions relative to PMDs. They've paused the prior authorization requirement around the DemiPost benefit. They've waived the signature requirement for signatures upon delivery. So you're able to use alternative means as long as you document within your paperwork that, designated it was during the COVID-19 emergency, and, you can document however that item was delivered, providing evidence aside from getting an actual signature from the beneficiary. There's provisions around accelerated and advanced payments for Medicare providers, and we'll touch on that in a minute. And then finally, there's relaxation of timelines associated with appeals. So we can provide additional detail as we, subsequent to this call, and that's again why we're going to be building on this as we move ahead. But there's a fair amount of information that is available around these items that's currently on the website. Let me pause here and I know we've got a couple of questions, so let me just read through these. Okay, the ATPA says we can bill for telehealth assessment. Again, things are moving fairly quickly, so I'm not going to argue with what the APTA may have put out there. I can only tell you what we've seen and what we're currently working on, that you need to differentiate between under what program we're talking about. So we have the federal Medicare program, which is obviously governed by CMS. And then we have the state Medicaid programs and other state commercial insurers. So what we have seen is on a state level, we have seen state Medicaid programs putting out announcements that PTs and OTs can bill under the telehealth provision, and they're able to provide whatever codes and services have been approved. So, and that, I think we're hopefully going to see an increase in that as we move through the next several days and weeks. But the federal guidelines right now seem to be fairly clear that currently PTs and OTs cannot bill under the telehealth benefit. Now, we have been told that CMS is looking at that particular question, and one of the things they're looking at is under the Cures Act that I mentioned a minute ago, which that has gives CMS some additional authority to expand the telehealth services. They're examining whether they can include OT and PT clinicians under that new authority. But as we sit here today, subject to anything new that might have come out today, that is one of the questions we're looking for. And frankly, we've communicated to CMS that when it comes to CRT access, it's critical that OT and PTs be able to provide remote services. That's the same message we're giving on a state level. As I mentioned, some states have already issued positive guidance that allows that, and for others, we're continuing to work on that. And when I say we, there's both, our work group, but also other organizations that are, weighing in on those same issues. Okay. AOT webinar said today that it's up to each state, and then most states require licensing in each state. So in other words, you can't, if you're not licensed in a state, you may not be able to provide those services. So licensure certainly is another question. But again, I think things are moving fairly quickly here. So we'll provide an update once we have a little more concrete information. But right now we are looking for the, something in writing that will provide some guidance on a federal level. And I certainly think if the CMS folks approve this from a Medicare perspective, that will help facilitate states taking that same process. But the good news is some states, and I'll just share particularly North Carolina, has issued specific guidance that does allow PTs and OTs to provide services on a remote basis. Okay, the pausing of the prior authorization, does that apply to the prior auth for power mobility devices? Our impression is that it does. In other words, when you look at the language in the PDF that CMS published, it refers to pausing of, in fact, I'll read it to you directly. The prior authorization in DMEPOS. CMS is pausing the National Medicare Prior Authorization Program for certain DMEPOS items. Now, the word certain DMEPOS items does give you pause, but as we know, the Medicare Prior Authorization Program only applies to certain DMEPOS items. So we're looking for some clarity on that. And I know I've heard different thoughts on whether that includes PMDs or not, but with some of this guidance, I think when you couple it with the overall theme that we're seeing around the relaxation of requirements to try and eliminate things that may not be appropriate in this time of emergency. Relaxation of that would seem to be the direction CMS would be going, but I think that's an example of, we get some initial guidance, we interpret it, but when we have questions, we're asking for some clarification on that. So there are folks that are working on that. If a person has Medicare primary, Medicare secondary, will Medicare pay if Medicare does not? Again, I think that's a good question that'll have to be handled by that individual state. And again, as we get clarity of these, as we move through the next days and weeks, we'll set up a way that we can hopefully share this on a broader basis. And I really appreciate the dialogue, because with so much going on, one of the things that I think will help is once someone gets something official in terms of whether it's a Medicaid bulletin or an article from a commercial payer or certainly something from CMS, those are the documents that are going to give us the detailed guidance that we all need. So the more we can share those, and certainly feel free to send those into NCARD and we can act as a clearinghouse, that'll help us all get more comfortable, and it'll also help us take that technical guidance, and we'll work on translating that into the, what it means from an operational perspective. And when I say operational, I mean, from a CRT provider perspective, and also from a clinical perspective, whether it's, a seating clinic or a home care situation. Those are all things that we want to try and take the technical guidance and provide some clarity on what that all means. Okay. All right, then I think this is a good segue. The next item we want to talk about is provide the clinician perspective. And Kathy Carver, who many of you know is the executive director with the Clinician Task Force. And so Kathy's been doing a lot of work within this area, and we asked her to maybe, share some overview and some of the things that they're working on from a clinical perspective. So Kathy, and that is Kathy, I guess we need to unmute you if you're not unmuted. So I guess I'm hoping you'll be able to speak up. If I don't hear from you, I guess we'll see if we can resolve that. Annette, I don't know if you can, are you able to see where?
Just a second, let me
Okay.
allow her to talk. Take just a second. There we go. Okay, Kathy, you should talk now.
All right, can you hear me okay?
There you go, Kathy. Thank you. Thanks, Annette.
Great. Greetings, everyone, from Birmingham, Alabama. Just wanted to give you guys a little overview of sort of what's going on the clinical front. We've been in touch with most of the CTF members across the U.S., which there's 80 of us in 36 states. So we've surveyed the group over the last week or so. And just to kind of give you a flavor of just the kind of current situation your clinicians are in, majority of them are in hospital-based clinics. And I would say probably of the people who responded to our survey, about a third of them have had to close their clinics for a couple different reasons. One, just due to lack of people wanting to come in, and then also the need to be moved to other parts of the hospital to help. So as far as access to a clinic, some trends are beginning there as areas that are hot spots and really getting more and more cases rapidly. The access to a clinician in kind of the traditional seating clinic setting is a little bit challenging in some areas. Other areas are still open and are screening patients and seeing them on a limited basis and on a kind of prioritizing type basis. They've set up sort of a protocol to talk to their patients about whether they should come in or not. So it's kind of case by case on if someone wants to come in and if they're low risk for COVID-19 and kind of meet that criteria. There are clinics that are still open. We are working to develop kind of a way to get some information out that would improve pathways to get to a clinician. And so after some feedback from today, hopefully we'll get something out to you guys in the next couple of days that might help just with ideas of how to access a clinician, either through if the clinic's open and they have telehealth options, or if they're open and they don't, or if the clinics are closed, are home health agencies an option? And if patients will let a supplier in, we'll kind of put out some ideas about that. Or if they won't, can we do remote access with both the supplier and the clinician if the patient has, access to a video type communication style. So we're working on a lot of ways to be able to get word out of ways to access a clinician, to keep the clinician voice and skill involved in being able to meet these needs. I think one of the big concerns obviously is clinician and supplier safety and health. So far, we've not heard from anyone that has gotten a positive test of the coronavirus. So we certainly want to keep that going because we know if we get sick, we surely can't help. But there is movement toward our clinicians moving closer to frontline assistance, especially in large hospital systems. So we'll keep you up to date on how the clinicians are doing and their availability to help. But I think good communication between the suppliers and the clinicians is helpful. I really appreciate the suppliers reaching out to especially the state Medicaid and the local commercial plans to see what telehealth options are available to keep the clinicians working side by side with you and communicating with the patients. I think one thing that is going to be of concern whenever we do settle down from this is the backlog and the wait list of people being able to get back into the clinic and get their needs met. So I think that's one thing that's weighing heavy on folks is being able to get those needs met on the back end if people decide to wait. I think one thing that we need to educate our patients on is that if they do choose to wait and choose to, which certainly we want people to feel good about, allowing people either into their home or coming into the clinic. We certainly don't want to push anybody one way or the other. But the longer they wait to have their assessment for what their needs are, the potentially longer the wait is going to be on the back end of if there's waiting lists or we have to slow down manufacturing, then we have to pick back up the manufacturing and that type of thing. I mean, the current waiting list in my own clinic is 65 people deep, just being able to call through my own referrals. So anyway, but we're trying to keep the tabs on how we can keep the clinician access there, and we'll get some information out over the next few days of ways we can keep the clinician involved in helping get these needs met. But do appreciate the teamwork, the good communication, and the good feedback that we're getting. So feel free to reach out with any questions or ideas that you have.
Great, Kathy. Thanks very much. And I think Kathy, some of the points Kathy touched on, I think just support, why we see today's call really being the first of many as we move through the next weeks and potentially months. We're all focused on the immediate needs and policy changes that we require, which is exactly what we should be doing. But also we know there's going to be a lot of other things that I'll say they're secondary, but certainly they're going to be significant in terms of ensuring people continue to get what they need on a timely basis. So the communication between manufacturers and providers and clinicians and others is going to be very important to make sure we can continue to provide the equipment and services that folks require. I did want to take a stop, and I see a question relative to the call. Unfortunately, it looks like some folks haven't been able to dial in because of a limitation. We did increase the call today, the capacity to 500 people, which we thought was a good number. And some folks apparently are getting a message that the limit was set at 100. We do have 127 attendees on the call right now, so we're not sure exactly what's going on from a technology perspective, but as I mentioned, the call is being recorded, and we certainly can put this call on again tomorrow for those that couldn't make it. So I think I'm safe in making that statement. We'll get something out to everyone on what the timing of that would be, but we certainly want to make sure everybody is able to access the information. and engage in some dialogue. So apologize for that technical glitch, and we will get it rectified and make sure we can get everybody involved as long as they are able. So,
Hey, Don,
okay, then,
am I
yes.
still on? I saw
Yes, you are,
that
Kate.
Jenny made a comment about the pediatric world, which I do want to make encouragement to people to reach out, especially to their state Medicaid programs, about telehealth access for speech therapy, occupational therapy, and physical therapy. Many, obviously, school systems are closed, and the government agencies for children's rehab services are also closed, depending on what your state governors have mandated. But I would encourage you to reach out to those state agencies and request at least some maintenance type things be available for kids. The COVID is not going to keep kids from growing and not going to keep kids from having their own secondary complications, being stuck at home. So do consider advocating on a state level. I know the organizations that are on this call have been great support to me for my own state to reach out. So I encourage you to kind of push a little bit for access in the pediatric world.
Yeah, great point, Kathy. And again, I think that's a good illustration of really a major issue out there that we aren't focused on right now because of the other immediate things. But as we all know, the kids that, with schools being closed, potentially, these kids aren't going to be back in school till next August or September. And, you've got all those situations, equipment that was to be delivered, new equipment that's required adjustments and other things. So that's what I'm referring to as I talk about as we peel this onion and start identifying other things and identify what we need to resolve those. It's going to be along the lines, just as Kathy was saying, is okay, let's, what's the issue, what's the solution and the messaging, and then how do we best reach out on a local and state level, because those things certainly are local and state issues. But that's another good example of, the types of things we want to talk about through this forum as we move ahead. Okay, we will keep moving. Let me just get to my screen here. Then on the couple of other operational things, certainly the safety of customers and employees is very important. So we wanted to refer everyone to some CDC guiding and some OSHA guidance that's available. And here again, we can share protocols and things as we move forward. I think learning what others are doing and what's working will be a benefit for all of us as we move ahead. On the business assistance side, there are some significant things that we want to make sure providers, manufacturers, and other organizations, this even applies to not-for-profit organizations, that there's some loans programs that are being offered for companies, particularly that have less than 500 employees, and they are, I say fairly generous, but not meaning that in a positive way. That the idea of having being able to cover your payroll for a certain period of time and maintain your workforce. There really are some, I think, creative things that have been made available to help businesses and organizations stay in operation and take away some of the financial pain, if you will. So I'd encourage you to check those out if it's appropriate, or share those within your own organization. And then also on the Medicare side, there's opportunities for accelerated payments to providers and suppliers. And again, we've got the link that gives you the detail for that information. And also there's a question on the PowerPoint. We will have this as a handout, and we'll send it out again through the Access to CRT system that I'll talk about actually as I'm speaking. And we'll also have it available through the NARTS, NCART, and US Rehab websites. So speaking of access to CRT, if folks have not been getting the email alerts, I'd encourage you to visit the website. Again, the website is www, the word access, the number 2, and then CRT.org. So access2crt.org. You can sign up there to get regular updates. They're only advocacy related, so you don't have to worry about getting marketing information. The website itself is what we call non-denominational, so it's not based on any one organization. NCART maintains and manages it, but it really is focused strictly on advocacy with the idea that people can use it as a reference and refer people to it as needed. So if you aren't getting alerts, I'd encourage you to sign up and certainly share this again within your organization. That way you'll be sure you're getting timely updates and be able to respond and engage as appropriate. And also, as I mentioned, that's a list we're going to use to send out the PowerPoint handout from today. And then on other helpful websites, we wanted to share that information. There's a couple of good sites that the federal government has set up. You know, we got and I'm not going to read the whole link, you'll see it in your handout, but the CMS.gov websites, and then also the coronavirus.gov. Also, Home Care has set up an excellent website with COVID-19 resources. We thank them for that, and you have a link there. And VGM, the VGM group has done the same thing. And then also HME News. So those links are available, and they're continually updated with new information that comes out. So I'd encourage you to check those out as appropriate. Okay, so our last slide, we wanted to talk about our next webinar, and we've tentatively scheduled this for next Thursday, April 9th at the same time, so a week from today. We're going to confirm that, but we'll be getting another alert out, and our various organizations will be sharing that, so you're aware of it. On the state side, if you're having issues within your state from a CRT perspective, if you could email those to McKay Lee here at NCART. We've got McKay's address on the handout, so it's mlee@ncart.us. And we're going to, again, want to gather what states are publishing so we can share that. And also, if you're running into issues relative to state coverage or policies, we're happy to assist in those. And at a minimum, we want to serve as a clearinghouse, and then ideally, you know, be proactive in whatever way we can. So thanks everybody for the call today. We do have some time, which we had hoped we'd have, so we're going to unmute our calls. I think, Annette, can we do that blanket unmute, or how best do we orchestrate that so if someone has a call, they can speak up?
Yeah.
Or should we just ask?
We can blanket unmute, or you can raise your hand and I can unmute you that way.
Yeah, if people want, well, yeah, if they're not on the phone, I guess, well, I guess why don't we try and unmute everybody? The risk of that, as you know, with 100+ people is we're going to get a lot of background noise. So if you could unmute, when we unmute you, if you could mute your phone if you're not speaking, that will make for a more effective call. So. So it sounds like at least some folks are unmuted. Again, if you're not speaking, if you could mute your phone, but if you have a question, again, you could still type it in the chat box or feel free to speak up. And while we're waiting for that, we did get a question on, you know, when I referred to pausing the prior authorization, does that mean they will not be approving shares? No, it does not. It means that they will not be requiring prior authorization for delivery and billing. So thank you for asking that, because that's a very important question. Again, a lot of these changes are designed to increase access, not decrease access. So what they're doing by that pausing, and I use that word purposely, pausing, because that's literally what CMS used in their announcement. So they're pausing the prior approval requirement for the time being. So it's just one less step that suppliers will have to go through when you're giving somebody a piece of equipment such as a PMD that's subject to that current requirement. Okay, another question. Can you clarify if the ATP evaluation home assessment can be done via telehealth, or are we still waiting on direction from that? Our sense is that, you know, the waiving of the in-person requirements that came out in the interim final rule sets the stage for that as an option. but that is something that we're waiting for more clarity in terms of how that needs to be documented and other things.
I've done this
So-
for a long time. I got my AT.
And someone, folks, if you could mute your phone, we're getting some background noise.
I've
So if you
only
could
done this
mute your call, that would be great.
part for the last 9 years, since 2011. Before that, I did mostly environmental